Okay, picture this. You're hitting the books late, trying to cram, but your skin is just crawling. The itching is relentless. It's driving you absolutely mad, especially when you're warm or trying to sleep at night.
Hmm.
It's not just irritating, it feels like something's actually under your skin.
Mm.
What could possibly be causing this intense torment?
Yeah, that sounds like a really classic presentation of scabies. It's one of those conditions that's, well, more common than you might think.
Yeah.
Just incredibly uncomfortable for the person going through it.
And that's exactly what we're unpacking today.
Easy.
Welcome to this deep dive focused entirely on scabies. Our mission is specifically tailored for you if you're revising for exams, like the MSRA. We want to give you a high-yield, focused overview straight from the source material.
Exactly. We're going to slice through the details to give you the essential knowledge. What scabies actually is, where it comes from, who's most vulnerable, what it looks and feels like.
Right.
How you figure out if someone has it in practice, and crucially, how to effectively treat it and, stop it coming back.
Think of this as distilling all that key information into a concise session designed to really stick in your mind. Let's jump right in. So at its heart, what exactly is scabies?
Okay, at its core, scabies is a skin infestation. It's caused by a tiny little parasitic creature, the Sarcoptes scabiei mite, and it's highly contagious.
So a mite is causing the problem, and the main symptoms people complain about.
Well, the defining features you'll see and hear about are that intense itching, the pruritus you just described, and a characteristic rash. Now, here's a really important point, a key takeaway for revision.
Okay.
The intense itching and the rash, they're primarily caused by the mite just like crawling around. They're actually your body's allergic or hypersensitivity reaction to the mites themselves, their eggs, and their waste products, their feces burrowed in the skin.
Okay, so it's not the physical sensation of the mite so much as your immune system reacting to these tiny invaders and, well, what they leave behind.
Spot on. That immune response is what drives the intense inflammation and that awful itch. And, while we might associate it with certain stereotypes, scabies can affect anyone, anywhere. It spreads primarily through close, direct skin-to-skin contact.
Right.
The female mite needs to burrow into the top layer of your skin, the epidermis, to lay her eggs.
Okay. So it's an infestation causing an allergic reaction, spreading via close contact. Let's get a bit more specific about the cause and how it works, the etiology. What species are we talking about here?
Yeah, it's caused specifically by the Sarcoptes scabiei mite, variety hominis. This one's adapted specifically to humans. And the female mite, she's the engineer here, she tunnels into the stratum corneum that's at the very top layer of your epidermis, creating those characteristic burrows.
And she's doing more than just tunneling while she's in there?
Oh, absolutely. As she tunnels along, she lays eggs along the burrow. Those eggs take about 10 to 15 days to mature. Once they hatch, the new mites emerge onto the skin surface. They mature, they mate, and the whole cycle just continues. An adult mite lives for about 4 to 6 weeks.
That's quite a life cycle happening right under the skin surface. How much contact is actually needed for transmission? Is it just like a brief touch?
Well, for typical scabies, transmission usually requires prolonged, direct skin-to-skin contact. The sources suggest this is generally around 10 to 15 minutes of sustained contact.
Okay.
However, there's a really important exception, especially clinically: crusted scabies.
The really severe form we hear about.
Precisely. In crusted scabies, individuals have a hyperinfestation. We're talking thousands, maybe even millions of mites. Because of this incredibly high mite load, transmission is much, much easier.
Right.
It can occur via contaminated items like bedding, clothing, or furniture, which is pretty uncommon in typical scabies.
And there's that crucial point about the timing of symptoms that's so vital for history taking, isn't there? The itching doesn't just appear overnight after you've been exposed.
This is a super high-yield detail for exams and, well, for practice too. The intense itching, that pruritus, it typically has a significant delay. It usually starts about 4 to 6 weeks after the initial infestation.
4 to 6 weeks. Why such a long delay?
Well, because that's roughly how long it takes for your body to develop the allergic sensitization to the mites and all their products. The immune system has to learn to react.
So someone could actually be infested, potentially spreading mites around, for over a month before they even develop the main symptom that brings them to a doctor.
Exactly. And asymptomatic transmission is also possible, which just adds another layer of complexity to controlling outbreaks, doesn't it?
Yeah, definitely.
It really highlights the need for a high index of suspicion, especially in potential exposure settings.
That delayed reaction is absolutely key to understanding its spread. So who is most likely to get it? What are the major risk factors we should be aware of?
Okay, several factors increase susceptibility. Crowded living conditions are a primary one, obviously, as they increase the likelihood of that prolonged skin-to-skin contact needed for transmission.
Makes sense.
Frequent physical contact with infested individuals is, well, obviously a direct risk. And while it's not the sole cause, poor hygiene can sometimes contribute, maybe in the sense of delayed recognition or perhaps a more severe presentation. But it's really crucial to remember scabies can affect anyone, regardless of how clean they are.
And certain locations just seem like perfect breeding grounds for outbreaks, don't they?
Absolutely. Institutional settings are the classic examples. Nursing homes, prisons, childcare facilities, basically anywhere people live or spend extended periods in close proximity.
Right.
Socioeconomic factors are also strongly linked. Things like poverty, living in refugee camps, malnutrition, and homelessness are all significant risk factors.
Dementia is listed as well, I noticed.
Yes, that's likely due to factors like reduced self-care capacity or maybe difficulty communicating symptoms early on. Sexual contact is another well-documented route of transmission,
Okay.
and certain populations are particularly vulnerable, children, especially in developing countries where prevalence can be very high and critically immunodeficient or immunosuppressed individuals.
Like patients with HIV or those on immunosuppressant therapy.
Exactly those groups. Their compromised immune response can lead to much, much more severe infestations, like that crusted scabies we mentioned. All these risk factors together explain why outbreaks can spread so rapidly in vulnerable or overcrowded communities.
So we know what the mite is and how it gets around. How does it actually cause the problems we see and feel? Let's dive into the pathophysiology a bit.
Okay. It all starts with that female mite burrowing into the upper layers of the skin, the epidermis. She then lays her eggs along the tunnel she creates as she goes.
And this is where the body's reaction really kicks in.
Precisely. The mite's saliva, the eggs she lays, and the fecal pellets, the sabala left in the burrow, act as foreign antigens. Your immune system recognizes these and mounts what's called the delayed type hypersensitivity reaction.
Ah, okay.
This is essentially an allergic inflammatory response happening within the skin itself.
So the intense itching and that rash we see are basically manifestations of that localized allergic inflammation.
That's the key mechanism, yeah.
Hmm.
It's your body sort of overreacting to the presence of the mites and their waste products just under the skin surface.
Yeah.
And as the eggs hatch, new mites mature, create new burrows, deposit more antigens.
The cycle just keeps going.
Exactly. The cycle of infestation and allergic response continues, which is why the symptoms persist and often get worse if it's not treated.
That makes perfect sense. Your body is constantly fighting these tiny invaders and their leftovers, as you put it. Now, that description, an itchy rash, could fit a whole lot of conditions. What else should be on our radar when we're thinking about scabies? The differential diagnoses?
Yeah, this is a really critical area for diagnosis and for exams, too. Scabies can be a great mimicker. You definitely need to consider common itchy rashes like insect bites, various forms of eczema, atopic, contact dermatitis.
The usual suspects.
Right. And fungal skin infections like tinea corporis. Also, don't forget secondary issues that arise from all the scratching like impetigo or other bacterial skin infections. Other possibilities on your differential might include conditions like lichen planus or psoriasis, although their appearance is often quite distinct if you look closely. Less commonly, perhaps in widespread or atypical cases, one might even consider things like bullous pemphigoid or certain systemic conditions causing a rash, but they usually have other prominent features.
So a broad list.
Yeah, the core task is always differentiating it from the more common causes of widespread itch.
That breadth of possibilities really highlights why a good history and a careful examination are absolutely essential. Let's look at the bigger picture then. Epidemiology. Where and who is most affected globally and maybe more specifically in places like the UK?
Globally, the prevalence varies hugely, often linked to those socioeconomic factors we talked about earlier. In the UK, scabies is actually pretty common and occurs in both the general community and frequently in institutions.
And which institutions tend to be hotspots?
Well, nursing homes, schools, and prisons are the well-recognized settings for outbreaks. Again, it's down to close contact and potential difficulty in prompt diagnosis and treatment across everyone.
Right.
Looking at UK demographics, some studies show it's somewhat more frequently diagnosed in females, and particularly in the sort of 10 to 19 age group. It also tends to be more common in areas with higher levels of deprivation and during winter months, possibly linked to people just spending more time indoors close together.
All those factors that facilitate that close contact. Okay, let's transition now to what you're actually going to see and hear from a patient you suspect might have scabies, the clinical features.
Right. The absolute hallmark symptom, as we've emphasized, is intense pruritus, severe itching. The classic history you'll hear is that it's worse at night, often bad enough to disrupt sleep significantly.
And remember that delay.
Yes, remember that crucial point. This intense itch often starts about 4 to 6 weeks after the initial infestation, not straight away. And just as importantly, the itch can persist for several weeks, even after successful treatment, because that allergic reaction takes time to settle down.
That's a really, really important piece of information to give a patient when you treat them, isn't it? Otherwise, they might think the treatment hasn't worked.
Exactly right. Managing expectations is absolutely key. Now, the rash itself, it's typically widespread and consists of small, red raised bumps. We call them papules, sometimes tiny blisters or vesicles or even pustules. And it tends to appear in quite characteristic locations.
Are there specific places you should always make sure to check carefully?
Yes, definitely. You want to look for lesions and signs in the interdigital web spaces. That's between the fingers, the wrists, elbows, armpits, the waistline or belt area, the genital area, and the buttocks. Now, for infants and young children, the distribution can differ significantly. They can commonly have lesions on the face, scalp, neck, palms, and soles, areas that are less typically affected in adults.
That's a good pediatric distinction to keep in mind. And the most telling sign on examination, the thing you really want to find.
Well, the absolute diagnostic sign, if you can find it, is the presence of burrows. These are the actual tunnels created by the female mite in the skin. They appear as fine, slightly raised, wavy lines. They might look grayish, dark, or silvery, and they're usually quite short, typically between 2 and 15 millimeters long.
Where should you look really closely for these burrows?
Prime locations are those interdigital web spaces again, the sides of the fingers and hands, the wrists. Sometimes you can see them on the areolae in females, and importantly, on the male genitalia. You might also see what's called the wake sign. That's the burrow ending in a tiny papule or vesicle where the mite is located, almost like a tiny trail ending with the creature itself.
Like a microscopic snail trail under the skin.
Precisely, yeah. An itchy microscopic snail trail. Another sign to look out for are scabies nodules. These are firm, reddish-brown lumps, often intensely itchy themselves, typically found on the elbows, in the anterior axillary folds of the armpits, and on the penis and scrotum.
Right.
These nodules are also a manifestation of a chronic allergic reaction and can persist for months after the mites are actually gone, even after successful treatment.
So persistent nodules, just like persistent itch, don't necessarily mean the treatment has failed either.
Correct. They're just a sign of that lingering immune response. Now, all that intense itching inevitably leads to secondary problems, as you can imagine.
I can well imagine. Scratching must break the skin barrier.
Exactly. Excoriation marks, just scratch marks, are almost always present. This constant scratching can also exacerbate pre-existing skin conditions like eczema. And crucially, those breaks in the skin surface are perfect entry points for bacteria.
Leading to infections.
Yes, leading to secondary bacterial infections like impetigo, which you'd see as crusting lesions, or even cellulitis. You might see the original papules or vesicles become infected, turning into pustules or larger crusts.
Okay, this brings us nicely to that critical, more severe variant we mentioned, crusted scabies, sometimes called Norwegian scabies. This sounds like a completely different beast altogether.
It really is.
Yeah.
This is a hyperinfestation, meaning the affected individual is carrying thousands, possibly even millions, of mites in the outer layers of their skin mixed in with the scale. It's a really high-yield area for revision because it occurs in specific populations and has a very different appearance and, frankly, a much worse prognosis if not managed properly.
Who is most vulnerable to developing this crusted form?
The most susceptible individuals are those who are immunosuppressed or immunodeficient. So think patients with advanced HIV/AIDS, those with leukemia or lymphoma, or individuals on long-term immunosuppressant medication like after a transplant. Also, the elderly, particularly those with cognitive impairment like dementia, or individuals with neurological conditions that reduce sensation or mobility, are also at increased risk. Malnutrition is another factor. Basically, their bodies can't mount an effective immune response to keep the mite population under control.
And what does it actually look like? Does it still have those typical burrows?
It looks very, very different from typical scabies. Instead of small bumps and maybe visible burrows, you see widespread, thick, scaly, crusted lesions covering the skin surface. It commonly affects the hands and feet, including the nails, causing thickening and discoloration of the scalp and the ears, but it can literally cover the entire body in severe cases.
Wow.
And because of the sheer amount of scale and crusting, those classic burrows are often completely obscured, not visible at all.
So you could easily mistake it for something like severe psoriasis or another chronic scaly skin condition.
Absolutely. Misdiagnosis is unfortunately common if you're not specifically thinking about it, especially in those at-risk groups. Associated systemic features can sometimes include generalized lymphadenopathy, swollen lymph nodes, and eosinophilia, which is an increased count of eosinophils, a type of white blood cell often elevated in allergic or parasitic conditions.
And the complications seem much more severe with crusted scabies, too.
Critically so, yes.
Yeah.
The thick crusts often develop deep fissures, cracks in the skin, which are major entry points for bacteria. A significant, potentially life-threatening complication of crusted scabies is severe secondary bacterial infection leading to sepsis.
Right.
It's also highly, highly contagious, much more so than typical scabies because of the sheer number of mites, and it's notoriously difficult to treat. Patients often require isolation to prevent spread.
Right. Definitely a distinct and very serious entity to be aware of. So given all these potential appearances, from typical to crusted, how do we definitively confirm a diagnosis? What investigations are actually helpful?
Well, the cornerstone is always going to be clinical evaluation, a thorough history, focusing on that itch and contacts, and a careful physical examination looking for those characteristic signs and distributions we discussed.
But what if you can't find a burrow, or the presentation is a bit atypical or tricky?
Yeah, that happens. Then you move to more definitive tests if possible. The gold standard is microscopic examination. You gently scrape a suspicious lesion, particularly the end of a suspected burrow if you can see one. Place the scraping on a slide with a drop of mineral oil or maybe potassium hydroxide, and then examine it under microscope.
And what are you looking for?
You're looking for the actual mites, their eggs, or mite fecal matter, those little pellets called sabala. Seeing any of these confirms the diagnosis definitively.
Are there other ways to visualize things, perhaps less invasively?
Yes, dermatoscopy can be very helpful. This involves using a handheld magnification tool like a dermatoscope, often with polarized light. It allows you to visualize structures within the skin's surface layers much more clearly, making it easier to identify subtle burrows, or sometimes even the mite itself that often looks like a tiny dark triangle at the end of the burrow, the delta wing sign.
Okay.
There's also the simple ink burrow test. You rub some fountain pen ink, for example, over an area where you suspect burrows, then firmly wipe the skin surface clean with an alcohol swab. If a burrow is present, the ink will track down into the tunnel and remain, appearing as a fine, dark, wavy line that wasn't obvious before.
Those sound like really useful practical steps, especially the ink test. The sources also mention some structured diagnostic criteria.
Yes, the International Alliance for the Control of Scabies, or IACS, developed criteria back in 2018. The aim was to standardize diagnosis, especially for clinical studies or situations where you can't easily get microscopic confirmation. They define different levels of certainty.
Okay, what are the...
So first is confirmed scabies. This is the highest level. It's achieved by seeing a mite, eggs, or fecal matter via microscopy, dermatoscopy, or maybe other imaging techniques. This is the definitive confirmed diagnosis.
Got it.
Then there's clinical scabies. This diagnosis is made based purely on clinical signs when you don't have that microscopic confirmation. It requires either the unequivocal presence of burrows seen on examination or characteristic lesions found in typical locations, plus a history of typical itching and contact with a confirmed or suspected case. It can also be diagnosed based on finding specific, typical lesions on the male genitalia.
Right, and the third level.
The third is suspected scabies. This is the lowest level of certainty. It's based on seeing typical lesions in characteristic sites, plus having a relevant history, so the itching and the contact history, or seeing atypical lesions in any location, but having both a history of itching and a history of contact with a confirmed or suspected case.
That structured approach seems really helpful for classifying cases, especially when things aren't completely clear-cut. Let's quickly try and apply that framework. Imagine a patient comes in, intensely itchy, widespread rash, but it's mostly on their trunk and legs, less classic sites maybe. You can't find any definite burrows on examination. However, they report that their grandchild, who visits them frequently, was recently diagnosed with scabies, and this itching is definitely keeping them awake at night. How would you classify this using those IACS criteria?
Okay, that's a good scenario. So based on those criteria, given the atypical distribution of the rash, but the presence of both key historical features, that intense itching and close contact with a confirmed case, this would fit the criteria for suspected scabies.
Right.
You don't have microscopic confirmation or visible burrows for confirmed or clinical scabies, and the distribution is atypical. But that strong history moves it beyond just being an undiagnosed rash. It really highlights the importance of digging deep into that contact history, doesn't it?
It absolutely does. Shows how those criteria work in practice.
Yeah.
Okay, so once we've made the diagnosis or have strong suspicion, how do we actually treat it? Let's talk management.
Right. The absolute non-negotiable golden rule of scabies management is that you must treat all household members, other close physical contacts, and any sexual contact simultaneously, regardless of whether they currently have symptoms or not.
Why is treating everyone at the exact same time so critical?
Well, because if you only treat the person who presents, but their partner or housemate or close family member is also infested, maybe asymptomatically or just in that early 4-6 week window before itching starts, the treated person will simply get reinfected almost immediately from the untreated contact.
Ah, okay. Ping pong effect.
Exactly. You have to break the chain of transmission for everyone potentially exposed all at once.
Treat everyone simultaneously. Got it. What's the primary treatment itself?
The standard approach is topical application of a parasiticidal cream or liquid. And this needs to be applied meticulously to the entire body surface.
To the entire body. You mean literally head to toe?
Pretty much. For adults, it's usually recommended from the neck down. But crucially, for infants, young children, and anyone who's immunocompromised, who are at risk of scalp involvement or crusted scabies, it must be applied to the face and scalp as well, being careful to avoid the eyes and mouth.
Oh, okay.
It needs to cover every single inch of skin, including behind the ears, palms, soles, between all fingers and toes. And you should use a brush to get the cream under the fingernails and toenails. And the product instructions have to be followed precisely regarding how long to leave it on. Typically, it's left on overnight for 8 to 12 hours before washing it off thoroughly.
Which topical treatments are generally recommended first?
According to current guidance, like they say CKS here in the UK, the first-line treatment is permethrin 5% dermal cream. It's considered very effective and generally has a good safety profile.
And if permethrin isn't suitable for some reason?
Yeah, if permethrin isn't suitable, perhaps due to a known allergy or maybe concerns about resistance, although that's less common, the second-line option is usually malathion 0.5% aqueous liquid.
Okay. And what about dealing with that intense, persistent itching? The treatment kills the mites, but the itch lingers, right?
Exactly. The itching often needs to be treated separately from the mites themselves because it takes time to settle. You can use topical crotamitin 10% cream or lotion, which has some specific anti-itch properties. Oral antihistamines are very helpful, especially sedating ones taken at night to help with that sleep disruption. Low-dose topical corticosteroid creams can also be used consciously for localized, particularly inflamed areas, but you want to avoid prolonged use or applying them to large areas. And again, you must reiterate to the patient that the itch will likely persist for potentially several weeks after successful mite eradication, just due to that ongoing allergic reaction.
Right, manage those expectations. And for the really challenging crusted scabies, is topical enough?
No, crusted scabies has such an incredibly high mite burden that topical treatments alone are usually insufficient to clear it. The treatment of choice is oral ivermectin, which is an antiparasitic drug.
Yeah.
This usually requires specialist advice, often from dermatology or infectious disease specialists. It might involve multiple doses of ivermectin, sometimes combined with topical agents as well, and often needs to be managed in a hospital setting with appropriate isolation precautions to prevent spread.
Makes sense. Beyond the medication itself, are there essential hygiene measures people need to take?
Absolutely. These are really key and are considered part of the overall treatment plan. On the day the first treatment is applied, all clothing, towels, and bed linen that have been used by the infested person in the previous, say, 3 days should be machine washed at a hot cycle, at least 50 degrees Celsius or 122 Fahrenheit.
And what about items that can't be washed easily, like shoes or soft toys?
Good question. Items that cannot be washed, like certain shoes, coats, or stuffed animals, should be sealed tightly in plastic bags for at least 72 hours, 3 full days. That's sufficient time to kill any mites that might have fallen off the body and can't survive away from a human host for long.
Do you need to go crazy disinfecting the entire house or use special insecticide sprays?
No, definitely not. Fumigation or extensive chemical cleaning of the house is not necessary and generally not recommended. Routine cleaning with standard household products is sufficient for surfaces like floors and furniture. Vacuuming carpeted floors and any upholstered furniture that the person has used frequently is also a good idea.
Okay, so just to recap the core treatment protocol then. Permethrin 5% first line or malathion 0.5% applied to the whole body neck down for most adults, but include face scalp for children immunocompromised. Leave it on as directed, usually overnight. And crucially, you mentioned repeating the application.
Yes, repeating the application after 7 to 10 days, the exact timing might vary slightly by guideline, but around a week later is absolutely essential.
Why the repeat treatment?
Because the first application kills the live mites and maybe newly hatched larvae, but it typically does not reliably kill the eggs that are already laid within the burrows. Repeating the treatment about a week later ensures that any mites which have hatched since the first treatment, but before they've had a chance to mature and lay new eggs, are also killed off.
Breaking the life cycle.
Exactly. It's necessary for successful eradication. Oral ivermectin, as we said, is an alternative, especially if topical treatment is difficult or contraindicated. And of course, you need oral antibiotics if there are signs of secondary bacterial infection.
What if you're dealing with an outbreak situation, like in a nursing home or a prison?
That requires prompt notification to the local public health authorities or infection control team. They will help coordinate mass treatment protocols for all residents and staff involved to control the outbreak effectively and stop it spreading further.
Right.
And one final point on management. Because scabies can be sexually transmitted, it's generally considered good practice to offer full STI screening to individuals diagnosed with it, as they may have acquired other infections concurrently.
That's a very good clinical pearl to remember. So, what can patients generally expect after treatment? What's the prognosis like?
Well, with correct diagnosis and strict adherence to that treatment protocol, especially treating the patient and all contacts simultaneously and repeating the treatment, the prognosis is generally excellent. The infestation can be successfully eliminated.
But the itch might hang around for a bit.
Yes, absolutely. Emphasize that to the patient. The itching and potentially those nodules we mentioned can persist for several weeks, sometimes even a couple of months, after all the mites are completely gone. It's just due to that lingering allergic reaction in the skin.
Right.
It doesn't mean the treatment failed, just that the body's immune response is taking time to fully calm down.
What's the biggest risk then to a successful outcome? What causes treatment failure usually?
The major risk by far is reinfection. This almost always happens if not all contacts are treated properly and simultaneously, or if those environmental measures like washing bedding aren't done correctly, or if the treatment wasn't applied meticulously enough or wasn't repeated.
So compliance is key.
Compliance and thoroughness are absolutely key. Prompt treatment for everyone exposed is vital to break that chain of transmission permanently. Now, for crusted scabies, especially in those with underlying immunosuppression, treatment can be much more complex. It might require longer courses or combinations of treatments, and the prognosis really depends heavily on managing the underlying condition as well.
And finally, what are the potential complications if scabies is left untreated or in those more severe cases?
Okay, the most common complications, as we've touched upon, are those secondary bacterial skin infections resulting from all the scratching. Impetigo and cellulitis are pretty frequent.
And crusted scabies itself is considered a severe complication.
Yes, you can think of crusted scabies as both a severe manifestation and a complication that occurs in vulnerable, often immunosuppressed individuals. As we detailed, it presents with those thick, widespread crusts and carries a much higher risk of further complications.
Like really serious infections.
Exactly. Secondary bacterial infections in crusted scabies can be much more serious, potentially leading to skin abscesses or even progressing to bacteremia and sepsis, which can, of course, be life-threatening.
Wow.
Other complications include the persistent scabies nodules we discussed, sometimes extensive dermatitis covering large areas of the body, occasionally progressing to erythroderma, which is widespread redness and scaling of almost the entire skin surface, and not insignificantly, significant psychological distress. This could be due to the severe itch, the chronic sleep deprivation, and sometimes the potential social stigma associated with having scabies.
That's a really comprehensive look at scabies, from that tiny mite causing all the trouble right through to the potentially severe complications.
Yeah, I think we've covered the main points for revision. The definition, how it spreads via contact, who's most at risk, the underlying mechanism of that allergic itch, what you'll see clinically, especially those burrows and nodules, and the different distribution in kids.
How to diagnose it using clinical signs, microscopy, and those IACS criteria.
And the essential management principles, especially treating all contacts simultaneously, repeating the treatment, the hygiene measures, and importantly, being aware of that severe crusted scabies variant and who is most vulnerable to it.
Absolutely critical points for anyone revising. So let's maybe leave you, the listener, with this thought to consider. Given how varied the presentation of scabies can actually be, especially with atypical lesions or those delayed symptoms, and considering how many other itchy rashes exist, how often might scabies actually be missed on an initial assessment, particularly in busy clinical settings or perhaps in patients who don't perfectly fit the classic demographic profile?
That's a good point. It truly underscores the importance of keeping scabies on your differential diagnosis list for pretty much any unexplained itchy rash and really taking the time to ask carefully about potential contacts.
Indeed. Well, that wraps up our deep dive into scabies for MSRA revision. For more free MSRA revision resources, do visit freemsra.com. And for the full premium revision toolkit, head over to pathomsra.com.